Hello, everyone. Welcome back to your anatomy lecture. Today, we're going to be taking a look at the knee joint, which will mostly be the ligaments as well as the connective tissues such as menisci and so on. But there are obviously the bones that'll be involved as well. So, well, let's just go ahead and get started. So, when we look at the knee joint, there will be at least a variety of different things. I mean, the bones themselves, the ligaments, and then different types of connective tissue, which can be hard or soft. They could be helping with lubrication or support. But then obviously there's blood vessels and nerves that'll be provided as well. Now, looking at the joint, it's mostly going to be composed of the femur, the tibia, the patella, and then in some ways the fibula as well. But largely the contact between bones is going to be between these three large bones, or the two large bones, and then the small bone that's on top. But there will be a variety of different connective tissues that'll be on either side. It'll be from front to back, back to front, and then everywhere kind of in between. So you can see that there might be some different abbreviations that you can recognize here, such as ACL, PCL, but there's also MCL, LCO, and then also VLO and VMO as well. So once again, though, let's talk about the knee joint itself. And if you look at the knee joint, you can see that it's composed of the femur, the tibia, which is in direct contact, which is going to be from the articular plateaus or the articular facets, and then also the condyles of the femur. But then on top, right on the front of the joint, although not necessarily a big place where weight is being put on, or rather where bones are kind of grinding against each other as much, you do have the patella that's going to be on the front, which is also very important because this is where a lot of tendons and ligaments will attach to as well. But if you look closely on the side, the fibula is here as well. And the fibula, although not really supporting much, not bearing much weight, it will have at least a couple of connections to along the lines of like a couple of different ligaments. So just to remind ourselves, if you look closely, we have the femur and specifically the distal femur down here. And this is where you'll have a few different major landmarks. But the large ones that we'll be looking at today will be mostly the condyles. So if you look at these large rounded projections, that's what condyles are. So you have your medial and lateral condyles respectively. And how do you tell that? If you look closely, you have the head of the femur. This is on the medial side, so this is on the medial side as well. So medial condyle, lateral condyle, medial condyle, lateral condyle. And these smooth, rounded projections is what's going to be able to be in contact with another bone very easily without very much pain, because it'll be able to fit right along with an articular surface that's going to be able to that it's going to be able to fit right along. But then on the sides, you also have a few different landmarks as well. If you look closely, you have epicondyles. You have the medial epicondyle and the lateral epicondyle, which are these smaller bumps on the sides. And then you also have the adductor tubercle, which is right above it. So medial condyle and lateral condyle, or sorry, medial epicondyle and lateral epicondyles are these small bumps on top of the condyles. So those are going to be these two. And then just to kind of go over a couple more things, because this actually does come into play a little bit. If you look in between the condyles, we have this area called the intercondylar fossa. So intercondylar means between the condyles, and fossa basically means a depression. Intercondylar fossa, that's going to be this area right here between the condyles. And then lastly, on the front of the femur, you have the popliteal surface, or sorry, on the back of the knee, you have the popliteal surface, and then you have the patellar surface on the front. So these surfaces are just basically whether they're on the front or the back of the knee, but the patellar surface is where the kneecap is going to be able to kind of float on top of. Although when you bend your knee, it will actually be able to be in some contact with it as well. Now, looking at the tibia, you're also going to see that you have some landmarks which will be relative to or which will be able to be in contact with the femur. And you can see the tibia is going to have a couple of smooth areas up here, and these won't be projecting outwards. These are going to be the facets or plateaus. So once again, you have a medial and lateral facet or medial and lateral tibial plateau, but you do need to also ask yourself which side is medial and which side is lateral. So if you look at this large bump at the distal end of the tibia, that is on the medial side, and it's called the medial malleolus. And that means that this is the medial versus the lateral tibial plateau or facet, if you'd like. And then right in between, you can see the intercondylar eminence, which is going to have the tubercles, like it's kind of coming off along them as well. But this intercondylar eminence is going to be right between the two condyles, which you can see over here on the front side of the tibia, which are these kind of rounded projections, not exactly how you usually see them, but kind of on the external side of the tibia. Now, looking at the patella is a pretty small bone, and oddly enough, there's only a few, or not oddly, but luckily, there is just a few small bones that we're going to be looking for here. And if you look at the patella, number one, ask yourself which side is the front versus which side is the back. So if you look closely, there is a rough, rounded side, and then there's a smooth inside or deep side. So the anterior side is going to be the rough side, which is going to be projecting outward. This is going to allow for various different ligaments and tendons to attach to it very, very strongly. While the smooth side, which is going to be the posterior side, the articular surface, this is the side that's going to be able to be in contact with bones, such as the patellar surface of the femur. So anterior side, posterior side, but then also looking closely, you have a top and a bottom. And a little bit oddly, the pointy part, which is usually kind of the top, is actually the bottom. So the apex, although, apex is usually the top, this is just the pointed part at the bottom, while the base is going to be the flatter, more broad side at the top. And honestly, there are medial and lateral surfaces, but those are very kind of difficult to differentiate. But just at least knowing that there's a medial and lateral side will be fine. Now to look at everything all together, you can see that there are a lot of stuff that's going to be surrounding this joint. I mean, there's a lot of these white bands, like big and small. And then there are also these connective tissues that'll be between the bones, which will include articulate cartilages, as well as these kind of significant, well, they're called crescents or crescent moon shapes, which are called menisci. So to talk a little bit about the joint itself, once again, it's where the condyles are going to be able to articulate with the articular facets, which will be from the femur down to the tibia respectively. And then you usually have the patella right on top of the front of the knee joint as well, while the fibula, although here, is not technically really involved in the joint part, but it is involved in the support part with different types of ligaments. Now, this is a very mobile joint. This is, 100% synovial, and then it is a diarthrosis, being extremely mobile, but this is not going to be a ball and socket joint. It is biaxial, as in there will be some amount of flexion and extension. That's like typical, this is technically not a hinge, but it's going to be going back and forth. But then there is a little bit of rotation that can occur along the tibia and along the tibia and femur, which is technically, well, rotation. So This is called internal and external rotation of the knee or leg, and there is a little bit of that movement that can occur here. So there are actually 4 movements that can occur, rather 2 planes of movement, flexion and extension, and then internal and external rotation. So just try to think about like your forearm with your radius and ulna. It is able to obviously flex and extend the elbow, but there was some amount of rotation between the two, which allowed for supination and pronation as well. So just to take a look at our first structures, you can see that you have hyaline cartilage. Hyaline cartilage is going to be covering the surfaces of these bones right on top of the femur and then right on top of the tibia. These are going to be articular cartilages that are going to be the first line of protection for the bones. So this is typically a very glossy, very smooth, and very slick cartilage. And it's not great to bring this up too much, but to imagine a drumstick. Have you ever seen that smooth kind of cartilage on the end of the bone? That's what the articular cartilage will be. So that articular cartilage is made up of hyaline cartilage, and that's going to be helping with protecting the ends of the bones itself. Without that, the ends of the bones would just like grind against each other, even with like those shapes that fit together. Hard things will break each other. So this is helping to protect them. Now, the patella actually is its own joint. So if you look closely, the patella is going to be resting on top of the femur, and it is going to be mobile. I mean, it does have ligaments and tendons attached to it, but it can actually move. And if you want to try it out, you can extend your knee and relax it, and then you actually can move it in multiple different directions. It can move up and down, side to side. Like there are actually 3 planes of motion. It is triaxial. So it is diarthrosis, it is synovial, like very mobile, but it is going to be able to move in almost any direction it wants because it is just mostly connected to the other bones by ligaments and tendons, almost floating on top of them. It has very little restrictions, but I mean, its major movements will be allowing for stuff like flexion and extension, but it is going to be able to move or rather glide on top of this joint. Now, interestingly, it's like when you do extend your leg completely or extend your knee completely, you actually have about no contact between the patella and then the articular kind of portions in the bone. Like it is just basically floating right on top of the articular surface or the patellar surface on the front of the femur, but basically it's just kind of like sitting right on top of the front of the knee. So it is helping to protect at least while you do have that soft part of the knee in the front, but it is also extremely important for the connections to the tendons of the quadriceps and then the ligaments, which go down to the tibia. So just looking at this list, you can see that there are a variety of different types of structures that will be attached to the knee. So the joint capsule number 1, this is something that we'll mostly see right now. And then synovial membrane, that is going to be internal, and we'll at least be able to see that there is a large cavity within the knee joint, and we should see some synovial fluid there as well. But then retinacular fibers, menisci, these are going to be small. Well, yeah, I guess technically smaller, but also a little bit more uniquely shaped, I suppose. While ligaments are almost always band-like, the menisci can actually be a little bit more specific in being kind of like a crescent shape. But then once again, you have all the ligaments. Cruciate ligaments, which include anterior and posterior. You have collateral ligaments, which include medial and lateral. And then you also have a couple of small ones like arcuate, oblique, And then lastly, bursae and fat pads that help to support the knee joint even further. So to take a look at these, number one, you have the joint capsule on the outside, but then on the inside, you have the synovial membrane. So the synovial membrane, I know we haven't really described joints too much, but basically, synovial membrane is a tissue that is going to be able to secrete a fluid called synovial fluid. And synovial fluid is a shock absorbing fluid, oddly enough. Like it is a fluid, but when you put pressure on this fluid, it actually becomes a little bit more solid or dense. So I don't know if you've ever seen the experiment where you have like a large amount of this, I think it's cornstarch substance. Like it is liquidy. It can flow. You can put things into it very easily. But if you try to like put a lot of force onto it, it becomes really solid. It becomes really dense. And that's what happens with synovial fluid. So the synovial membrane makes that fluid that rests inside, but the synovial membrane is basically lining the entire inside of the knee joint. Now, there is one thing that you may recall that we talked about earlier, but there is this small connection to a muscle that's deep to the knee joint, or sorry, deep to the quadriceps, and that's going to be the articularis genu. And you can see that tiny little muscle right there. And basically, this can pull on the synovial membrane to make sure that it can stay coordinated with the movements of the knee. So you have the synovial membrane on the inside, and then basically encapsulating the entire knee joint, you have the joint capsule. So you have this for basically every synovial joint, but the joint capsule, I mean, just to point it out, is going to be this large amount of connective tissue that's covering the entire thing, even like beyond and superficial to the ligaments. So this is going to be just surrounding the whole joint. Uh, that's kind of its thing. So joint capsule, this is a little bit more general. It'll be all the way above the condyles, below the condyles, and surrounding the whole joint. Now, this is going to be something that is important for the knee joint, but if you look at the quadriceps, there are a couple of, or we talked about the quadriceps tendon coming from the rectus femoris, but we did not really talk too much about how the vastus muscles attach to the patella, or rather the tibia. And if you look closely, you have these connective tissues, which are going to be able to kind of surround the knee joint, or from the front, from the vastus medialis and vastus lateralis. So from the vastus medialis and vastus lateralis, you have these things called reticular fibers. So the reticular fibers are going to be helping to kind of connect along the sides and then extend down to these other connective tissues that we'll have here as well. So retinacular fibers, these are going to be able to connect from the vastus medialis and vastus lateralis, and those are going to be going along the sides of the patella to help with connecting to it, along with the quadriceps tendon. Now, looking a little bit more internally, we can see that we have these pretty big connective tissues here and a little bit more unique as well, like the ones that I kind of bring up regarding its shape a lot. You have these crescent moon shapes called the menisci. You can see that right here as well as right here. These menisci are going to be curved and rounded, allowing for the femur to rest right on top of it. Sorry, give me 1 second. Sorry, dog had to go outside. But the menisci. The menisci, you can see that you have these two kind of rounded shapes. These help to encapsulate the condyles of the femur a little bit more. So it's not just resting on top, and it doesn't just have that curvature, it has a larger rim to hold the condyles of the femur in place as well. So it's crescent shaped, but it also has a bit of a wedge with a thinner part on the inside and a thicker part on the outside, helping to form a bit of a rim along the bottom of the femur. So these will be the medial and lateral menisci respectively. And these connective tissues, just like cartilage and just like ligaments, are mostly avascular. So if you've ever had like a injury to one of these structures, you may have noticed that it's extremely slow healing. I mean, in contrast to even bones, but also skin and so on. That's because it's mostly avascular with a poor blood supply, but they do have a blood supply from your genicular arteries, your inferior medial and inferior lateral genicular arteries. Now, looking closely, you can see that you have two different menisci, and if you look at this little area over here, you can find that you have the fibula, which means that this will be the lateral meniscus versus the medial meniscus. So as usual, look for those landmarks to tell which side you're on, and the tibia is always medial while the fibula is always lateral. So we know that this is the medial meniscus. You can see that it's a pretty, crescent moon shape, and it's a little bit more like a C. So it's not quite as enclosed as the lateral. It has a little bit more of an opening along its internal edge. But if you look on its external edge, it actually has a pretty strong connection to the medial collateral ligament. So this is typically a very immobile portion of the knee joint because the medial meniscus is very strongly attached to the medial collateral ligament. So since these two are so strongly attached, these two are very hard to displace, meaning that if one gets torn, the other typically gets torn as well. And it gives a lot of support, but it also gives slightly less flexibility. Now, looking on the lateral side with the fibula, you can see that you have the lateral meniscus. And in contrast to the open side on the internal edge, this side is going to be a lot less or a lot more enclosed, where it almost forms a complete circle. So this is still kind of a crescent shape, but it goes all the way to here and here, where it only has this little opening along its, well, in this case, medial edge. So look closely though, with the lateral meniscus versus the lateral collateral ligament. There is going to be a space between them. So it is not as strongly attached or not attached at all. Like it is going to basically be separate from the lateral collateral ligament, which is in stark contrast to the medial collateral ligament. So you actually do have a bit of a pocket between the two, and that should be visible when we look at it on the cadavers as well. Now, along with the menisci, you have some supportive structures that you can see here too. And if you look closely, you have a couple that are going along the front and back, and then you have ones that are interconnecting, and then you have some along the edges of the menisci as well. So first of all, number one, if you look closely, we have the transverse genicular ligament. So the transverse genicular ligament, I don't want to enlarge it, but here. The transverse genicular ligament you can see right here. This right here, this thin band going across, this is right along the front and connecting the anterior edges of the menisci. So this is going to be the transverse genicular ligament going across from meniscus to meniscus across the front of the knee. And then while we're kind of still blown up here, you can see that you have a couple of connective tissues right along the bottom of the menisci here. And you can see one here, and you can see one over here. These are right along the margins of the menisci to help with supporting those as well. And then if you look closely, although we haven't talked about them yet, we have the ACL and PCL, and then along with them, there are some smaller regions. So if you look closely right here and right here, these two are actually connecting from the meniscus and then to the femur. So not from the tibia to femur, but from meniscus to femur. These are called meniscofemoral ligaments. And respectively, you have an anterior one and a posterior one, which are good to look for being next to the ACL or PCL. But just be careful, these are connecting to the menisci. So you have the anterior meniscofemoral ligament and the posterior meniscofemoral ligament. So from meniscus to femur. Now that leads us to our next big group of ligaments, or our first group of ligaments, which are the cruciate ligaments. Now, if you've ever heard of the term cruciform or crucifix, you might know what cruciate means, which basically means a cross. So typically you think of a cross kind of like this, but a cross in this case is still a cross. So you have one that's going from front to back, whatever side you want to be front. So front to back. And then you have one side going from back to front. So when you have those two ligaments, they actually cross kind of like this, and they're going to be very internal and deep to the knee joint, which means that you typically only see either one side or the other at any time. But you can see in this case, the anterior cruciate ligament versus the posterior cruciate ligament. And then while I'm pointing at it, look closely, you can see the posterior meniscofemoral ligament right over here, right next to the posterior one. So these are pretty well-known ligaments because these are the ones that get injured quite a lot, and these are known as the ACL and PCL. So the ACL, the anterior cruciate ligament, so when you talk about cruciate ligaments, you want to imagine what side do they go down to the tibia. So if it's the ACL, it's going from the back of the femur to the front of the tibia, and that's where you'll see it attached. So this right here, when you look at the anterior side of the tibia, you can see like tibial tuberosity. This is definitely the front. This right here is the anterior cruciate ligament. So anterior cruciate ligament, it's attached from the femur to the front of the tibia. And this, in a kind of interesting way, is going to be able to resist extension of the knee. So when you have extension of the knee, as in like your leg extends, your leg straightens out, that's where your ACL is going to be working. So it's a little bit odd to think about, but that is when the most force, and that's when the ACL will become taut, and that is going to be during excessive amounts of either moving the tibia or moving the femur too far forward or the tibia too far back. So, oh, sorry. Well, basically, when you extend the knee, here I have a picture. So when you extend the knee, that's when the ACL gets kind of taut, and that's when the femur is coming too far anteriorly, or the tibia is going too far back. So in this case, that's when you can see that the ACL is going to be taut, and that's when it's going to have the most force being put onto it. So ACL, anterior cruciate ligament, that's going to be on the front over here, which is going to be helping to resist extension. Now, posterior cruciate ligament. This is going to be when the one that goes from the femur to the back of the tibia. And when you look at the back, you can see that right here, this is the posterior cruciate ligament, and that's where you can see the ligament attached to the back of the tibia. So in this case, when you flex the knee, interestingly, that's when the posterior cruciate ligament is going to be the most activated. That's when it's going to be able to resist the most force for the knee, which is when the knee is flexing. And I am not going to try and describe it in the way that I did before with like the movements of the joints, because they're kind of respective or relative. So just flexion. When you resist or when you have excessive amounts of flexion, that's when you'll have the PCL being activated. So if you look closely, when you have the PCL or when you flex the leg, that's when the PCL is being pulled on more and the ACL is being pulled on less. So the PCL is going to be able to resist more flexion, while extension, it'll be a little more relaxed. So ACL is helping to resist extension, while PCL is helping to resist flexion. Now, that brings us to an interesting place, which is called the patellar ligament, which some people call the patellar tendon. So just to kind of describe this a little bit, sometimes people will call this the patellar tendon because this technically is kind of like a straight path from your quadriceps muscles to your tibia. So in a way, this is helping to connect muscles to bone, but just to be clear, in my class, patellar ligament is from bone to bone. So just to kind of break this up, quadriceps tendon is from the rectus femoris down to the patella, but then from the patella down to the tibia, this area is the patellar ligament. So patellar ligament is still bone to bone, but it is very important because this is how the quadriceps muscles will all be able to insert onto the tibia down here at the tibial tuberosity. So patellar ligament, although sometimes you will just hear it as patellar tendon, which actually can sometimes just encapsulate all of this with quadriceps tendon as well. But in this class, we are a patellar ligament household. So patellar ligament and then quadriceps tendon down here or up here. Now on the sides of the knee, instead of being cruciform, these are called collateral ligaments. So cruciform were the ones that cross, collateral are just on the sides. And respectively, you have a medial versus a lateral collateral ligament. So if you look closely, the fibula is on the opposite side, and this is where you have the tibia, meaning that this is medial collateral ligament. So medial collateral ligament, you can see that right here, and it is going to be a relatively broad and thin connective tissue, but also remember regarding the menisci, it is going to be strongly attached to the medial meniscus. So this is going to be a point where injuries can occur, and it is going to be helping to resist valgus forces. So if you look closely, valgus or valgum is when your knee joint or when your joint in general is sticking out laterally. What that means is your knee joints are kind of protruding inward. So when the angle projects outward, that's called valgus. But when the point or when the knee points inwards, this is valgus. So it's kind of a dumb way to remember it, but the way that I've been told is that when you have valgus, this is when there's gum between your knee joints and it sticks together. So this is valgus or valgum, which is when you have gum between your knees and they stick together. And in this case, this is going to be stretching the internal ligament, which is the medial collateral ligament. So this one on the side that's being bent, this is going to be shorter as they become close together, but the side on the outside is going to be taut and pulled on, which is the medial collateral ligament. Now, the lateral collateral ligament, you can see, is in stark contrast to the medial, very small, and once again, detached from the meniscus. But you can see that right here with the lateral collateral ligament. And in this case, different from basically everything else so far, is attached from the lateral epicondyle in this case, but to the head of the fibula. So this is the ligament that attaches to the fibula. I mean, the fibula is here. It just doesn't really help that much in the knee joint, but in this case, this is one of the ways it does. So you can see that you have the lateral collateral ligament, and that's going to be on this side, much skinnier, as well as separate from the menisci underneath. Now, in this case, this is going to be helping to resist the opposite, where in this, or if you look at this lower extremity, this is not how people stand. This is actually bending the knees outward too much. And what that means is that the angle is pointed inward, or is pointed inwards, or excessively inwards. And that means that there's going to be stress on the outside of the leg instead. So, or sorry, on the outside instead. So when you bend the knee outward too much, that means that this one will be stretched, the lateral collateral ligament, which is when you resist varus forces. And I have one more way that I've remembered this, which is when you have varus, that means that you're trying to ride a horse. And I know that's a big leap, but horse has an R in it, so does varus, while valgus does not. So use it if you want, but that's kind of like the way that I remember it, at least with both of them together. I'll remember it in some form or fashion. Now, if you look closely, there are a few more different ligaments which are a little bit thinner and smaller, but the first of which is called the oblique popliteal ligament. Now, you can kind of guess what this means based off of its name. So number one, popliteal ligament means it's in the back of the knee, but oblique means that it's diagonal. So this is actually going to be going from the medial condyle of the tibia over here to the lateral condyle of the femur. So medial tibia to lateral femur. This is the oblique popliteal ligament. And to be honest, we don't see this too much because it often gets cut when we do the dissections, but at least you can see it here. And this right here would be the ligament. And this is going to be taught when you have knee extension, because when you have your knee being extended, straightened, it's going to pull on this ligament as it goes, or as the tibia or the femur goes forward. Now, another ligament that's a little bit small is going to be the arcuate popliteal ligament. And the arcuate popliteal ligament you can see right over here. So the arcuate popliteal ligament is going to be right along like the popliteus muscle. It's, well, basically kind of right along its medial aspect. And that's basically it. In a similar fashion to the oblique ligament, it is also going to be taught with knee extension because it is on the back, and when the knee extends, it will be taut and pulled on. Now, there's a bunch of bursae that are going to be along here, but we won't talk about all 12 of them. But if you recall, bursae are these connective tissues which help to support the joints even further and often have little pockets of additional synovial fluid as well. So the bursae, as well as the fat pads, help to support the knee joint even further. And you can see that there will be at least a few different pockets that you can see here. But if you want to see them and name them, you have a few. So a few as in like, in this case, half of them are 6. So luckily the names are pretty specifically where you find them. So to start off with, prepatellar. So if you look pre-patellar, that's where you're going to find this one, basically outside of the patella. So subcutaneous prepatellar bursa, this is the one kind of outside of the patellar ligament and quadricep tendon, right over here on the front of the knee, basically right under the skin, but on top of the patella and ligaments and tendons. But then that's where you'll have both supra and infra patellar bursae as well. And since there's only one supra, let me just point that out. If you look above the patella, you have the suprapatellar bursa. So suprapatellar bursa. And then also underneath, you have two different bursae, either the subcutaneous infrapatellar bursa or the deep infrapatellar bursa. So you have one basically right on the anterior or posterior side, or deep to or superficial to the patellar ligament, which will be underneath the skin or underneath the patellar ligament. So deep or subcutaneous infrapatellar bursa. And then you also have the anserine one, or the anserine bursa. And the anserine bursa is underneath the pes anserinus, or pes anserine. So if you look closely, this right here, along the medial side of the tibia, this is where you have muscles such as the gracilis, the sartorius, and the semitendinosus attached. And that's where you have the anserine bursa right underneath this broad connective tissue. But then specifically underneath semimembranosus, you also have another bursa right here, which will be the semimembranosus bursa, basically. So that's, I think, enough bursae, but you have one on top, two underneath, two in the front, and then a couple on the medial side, which will be the semimembranosus as well as the anserine bursa. Now, I think we talked about this a lot before, so I'm not sure if I feel like we need to talk about this too much more, but just remember, the knee joint, I mean, although it is mostly ligaments and tendons, there are also a lot of connective tissues and even like bony structures as well. So there are a variety of different arteries that will supply it. So this is where you'll have the medial and lateral superior genicular arteries, medial and, or sorry, anterior, oh, no, superior and inferior medial genicular arteries, superior and inferior lateral genicular arteries, the middle genicular artery, and then also from the thigh, the descending genicular artery, which is going to be coming from like the profunda or the femoral artery, and then also the recurrent arteries that come from the anterior tibial artery and the posterior tibial artery. So a lot of arteries that's going to be around the knee joint, but that's important because the knee is important. And then in a similar manner, you have innervations to the knee, and luckily, you basically have nerves on every side of the knee. But whatever side it's on is going to be what nerve is innervating it. So you have the tibial nerve in the back, you have the common fibular nerve on the lateral side, you have the saphenous nerve on the medial side, and then you have the femoral nerve on the anterior side. So you have a few nerves, but whatever nerve is on that side of the knee is literally what's innervating it. So common fibular, lateral, saphenous, medial, tibial, posterior, and then femoral extends all the way down to the knee to go to the anterior side of the knee. Now, lastly, to just bring up this one thing, which is something called Q angle, which is helping us to measure kind of the angle of the joint, because as we saw, there are different abnormal positions for the leg and the knee, or the leg and the thigh. But to help with measuring that, you can use what's called the Q angle. So the Q angle, if you go from the anterior superior iliac spine down to the patella, and then from there at this cross section, go straight down the tibia, that is what we know as the Q angle. And the Q angle in normal measurements is about 170 to 175, so relatively straight, but not completely. But if you have excessive amounts of valgum or verum, and if you remember, Valgum is when the knee is kind of projecting inwards, which is making that angle less than 165, that decreases that angle. Or if the joint becomes much more straight, which excessive verum, as in like 180 or above, that is going to be putting different types of forces on the knee, which is a little bit abnormal. So just to kind of give you a thought regarding that, when you have excessive amounts of valgum or verum, think about how the Q angle will change. Is the Q angle going to increase or decrease? And then also which ligaments are going to be involved in that. So I'm not going to have you measure anything, but at the very least, know whether it's above or below those critical points, which above 180 is pretty clear, but also below 165. So I know I showed them individually, but look closely, and you can see that the normal stance is not completely straight, but it is going to be with this kind of slight angle, like going down from the anterior superior iliac spine to the patella, and then down the tibia. This is a slight angle right here. And I know I'm just not making a good description of this, so just let me briefly try to do that for you real quick. So one and two, and why did I choose white? Okay, it's kind of gross looking, but there's green. So you can see that this angle right here is slightly bent, is not 180 degrees. It is 170 to 175. So this is normal, but if it is greater than 180, so just to kind of show you that. So just to kind of show you 180 real quick. Let me. So 180 would look like this. And this is bowing out even a little bit more. So this is above 180 degrees. And then if the angle is more bent, that means that there's more of an angle right here. So just to describe this one more time, normal is 170 to 175, slightly angled. But if it's too straight, or even if your knees bow outwards, that's when you have something called varus. And think real quickly, which ligament is going to be pulled on here, or which one is going to have more tension. And that's the lateral collateral ligament. And then if you have too much valgus or valgum, that means that this angle is too small now. And that means that this is going to be pulled on the medial side. So with valgus or valgum, you're going to have too much force being put onto the medial collateral ligament instead. So with that said, though, that should be just about it. So if you have questions, please let me know. But good luck with your studying. Thank you for listening, and I'll see you all next time.